and more people will come in as we go through. Hello, Chelsea. Thank you so much for offering this incredible opportunity for our Wayne State University students. My name is Anika Sood, and I'm a PR rep for Club Med Virtual. I'll be leading today's session, reading any comments posted in the chat, and facilitating the conversation as we go along. Before we start, I just want to remind everyone to maintain proper etiquette and please keep themselves on mute unless Chelsea specifies otherwise. If you have any questions, please post them in the chat and they will be addressed as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will close 30 minutes after the session terminates. Please stay on the call at least for 5 minutes after the session to ensure the survey is working for you. The session will be posted on YouTube in case you're unable to attend or want to visit certain topics Chelsea discusses today, but you cannot receive attendance hours if you are not present during the call and complete the survey. Other than that, I'll hand it over to Chelsea whenever you want to begin.
Thanks, Anika. Can you make it accessible so that I can screen share my presentation, please?
Yeah. I think
you just have to make me a co-host so that I can share my presentation. Usually that works.
Okay. Make co-host. Can you do it now?
All right. Yep, I should be able to share. So now everyone should be able to see the screen that I'm seeing. Can you all see that?
Yeah.
Awesome. All right, so I graduated, just a little bit about me. I graduated from Clarkson University in May of this year, and I chose to do a PA residency as opposed to accepting a new grad position. I was offered a couple of new grad positions, but specifically being in cardiac surgery, you don't get a lot of critical care medicine or surgical training in PA school, and that's just something that I wanted extra of. So although I'm a board certified PA, I'm technically a resident, so it's just like a medical residency. I go, I see my own patients, I order my own medications, but like in the OR, I'm more of a student. I'm learning how to operate. I'm learning how to harvest veins, those types of things. So for my case presentation today, I wanted to give you guys kind of a really unique case that we can see in cardiac surgery. It's honestly very common, but very rare outside of cardiac surgery. So a lot of people don't even know about this disease state. I encountered this on my actual rotation in January, and it was just such a great case and why I wanted to be in cardiac surgery that I decided to represent it to you guys. So I have presented this at a grand rounds prior. So it's called Paralyzed by Love. So this is our patient. He's a 77-year-old Caucasian male. He's presenting with exertional dyspnea. So I'm probably going to be using terms that some of you may not be familiar with. So if you're not familiar with them, please stop me and I'll try to explain them better. So exertional dyspnea is any type of physical exertion that causes difficulty breathing. So that's dyspnea. So his past medical history is significant for congestive heart failure, severe mitral regurgitation, non-ischemic cardiomyopathy, atrial fibrillation, and Mobitz type 2, status post-permanent pacemaker, type 2 diabetes, and high blood pressure. So over the last few years, he's been experiencing difficulty breathing, and initially it was relieved by his pacemaker, but over the last couple months, he feels like it's worsening, and now like even at rest or with simple daily activities, he feels short of breath. He doesn't have any chest pain. He doesn't have any palpitations that's feeling like your heart's fluttering. He hasn't passed out. He underwent an echo, so a TEE, right on the chest, and it showed severe mitral regurgitation with an ejection fraction of 45%. So our team evaluated him and he was scheduled for a cardiac cath. So my question for you guys, I'm going to try to make this interactive, and I don't expect any of you to know the answers to these. So if you don't answer in a few seconds, I will just answer. But does anyone know what a normal ejection fraction is? So normal ejection fraction is going to be 55% or greater. borderline 50%. Some texts will say that that's normal, but really it should be over 55% for your heart. So that's how much blood your heart can pump out to the rest of your body. So his medications and allergies.
Chelsea,
the biggest
sorry
thing.
to interrupt, but I don't know if this is just me, but I'm stuck on the first slide.
You're stuck on the first slide. Can anyone else see the second slide?
No.
I think you're just sharing one screen at a time, and when it goes into a presentation, it switches.
Okay, then I will undo the presentation and let's see if that works. And we'll just keep it like this. Is that better for you guys? Can you see that?
Yeah.
Okay,
Yes.
great. Sorry about that. So medication wise, he's taking, atorvastatin for his high cholesterol. He's taking Bumex for his high blood pressure, Coreg for his congestive heart failure. It's important to know that he's taking lisinopril for his high blood pressure. That'll be important later. But he has an allergy to penicillin. And does anyone know why this allergy would be significant for a surgical patient?
Because it's an antibiotic, and you always want to introduce an antibiotic when you're opening a wound.
Great, excellent. Yeah, so we use cefazolin in the operating room, usually an hour prior to incision, and cefazolin is part of a penicillin group, so we wouldn't want to administer that to this patient. Good job. So the remainder of his history, we pretty much went over in his HPI. He was a smoker. He did drink very heavily in the past, like 2 beers every single day, but now he pretty much just has it on the weekends. Otherwise, it's non-contributory. So his physical exam, it is notable that his BMI is 42, so he is overweight. But otherwise, he's in no acute distress. His ENT exam, so eye, ears, nose, and throat, is pretty unremarkable. He has a class 3 airway, which is important for surgery because that's for intubation. So that's usually where you can see the uvula just barely at the top, but usually the tongue's covering the majority of that. His heart, he has a systolic murmur heard at the left sternal border with radiation to the axilla. So does anyone know how to tell whether a murmur is systolic or diastolic? So you correlate it with the pulse. So if you're listening to the heart in whatever area that you can hear it best at, and then you feel the patient's pulse, if it correlates with the pulse, it's systolic because that's when blood is being ejected from the heart. And if it does not go with the pulse, it is a diastolic when the heart is relaxing. Otherwise, his lungs and abdomen and his neuro exam were pretty normal. His vascular exam, he did have some brown hyperpigmentation to both of his legs with some pretty significant swelling. He didn't have any history of vascular disease, but that hyperpigmentation is pretty consistent with a peripheral vascular disease. So if he had like a coronary artery disease, that would be pretty bad if we wanted to take vein from the leg because the veins probably wouldn't be working very appropriately. And the swelling is from his mitral regurg. It's backing up into his lungs, which backs up into the right side of the heart and then to the rest of the body, causing kind of a congestion type of situation. So pre-op for cardiac surgery, a lot of our patients are already admitted to the hospital and we get consulted by cardiology. So a lot of their labs are already done. We don't really order much, but we look at specific labs in cardiac surgery. So we want to know their creatinine. So this patient's creatinine was 1.5 at baseline, which probably tells us that he has some sort of kidney disease, whether that's acute or chronic. Would depend on how many trends in his creatinine we have. He had only been admitted 1 day, so this was the only one we had to go off of. So we have to base that this is his baseline. And patients with kidney disease are at higher risk when they undergo cardiac surgery. So that's important to know. His BNP is a natriuretic peptide that actually gets released from the heart. And when it's elevated, it can signify a congestive heart failure, which we know this patient has. We look at their coagulation studies because obviously we're opening up the heart. We want to know, like, what's their bleeding risk? Are we going to need to transfuse this patient? His are all pretty normal. A1C is for diabetes. We know he has diabetes, but a 5.7 is actually a great A1C to have going into surgery. A lot of our patients will have like 9. So we want to make sure that they don't have any history of MRSA, because that would also change the pre-op antibiotic we'd want to give in the operating room. He doesn't have a history of a staph infection, so we didn't need to worry about that. And then we know that he has mitral regurg from his echo previously. So for his cardiac cath, you can see here where this arrow is, he has significant stenosis of this coronary artery. Does anybody know the name of that artery and why it's so important? So that is the left anterior descending artery, or the interventricular septal artery. In practice, we call it the LAD, but probably in like your anatomy and phys, you'll call it the interventricular septal. So it's important because it supplies 70% of the blood to the heart. So if this isn't working, the risk of you having a MI or a heart attack is really high. So it's important to know that he has this significant stenosis, because then we're already going in to fix his valve. We can go in and bypass this artery while we're in there. And this is the most significant artery that you'd want to bypass on a patient. Anytime there's over 50% stenosis, we want to make sure that we bypass that for a patient, because their risk of heart attack is pretty high at that point. So just by looking at this, I would say that's probably like 80 to 90% stenosed. If it were occluded, you wouldn't see any filling down here at all. And you'd probably see these marginal arteries bringing collateral flow to that aspect, because your heart's pretty smart. And it tries to send blood to places that doesn't already have blood. So our patient's preoperative diagnosis is pretty much what we thought, but after his cath, now we know that he has coronary artery disease, including the mid left anterior descending. So I go in to meet my patient. He pretty much looks like this. He's being intubated. This is kind of how I felt looking at him, because, you know, I'm on rotations and I didn't really know what to expect. This was probably my first week on cardiac surgery. So this is kind of a little overview of the beginning of the surgical procedure. So this is kind of what we do. You go from the sternal notch. So if you feel on your chest, there's this little indent right at like the bottom of your neck. That's called your sternal notch. So we make the incision from there all the way to where it gets soft down right at the top of your stomach. So that's the xiphoid process, because we need to get through the entire sternum, right? So from here all the way down to here. And we saw through that with a bone saw to get to the heart itself. We open up the pericardium and we kind of take sutures and tie them up to the retractors so that we can actually see the heart itself. Now, if we had more than just the LAD being blocked, the PA would be down at the leg harvesting a saphenous vein, but that's not the case for this patient. We just wanted to use this artery right here, which is well, technically it's this one because you're looking at the bottom view, but the lima, so the internal mammary artery or the internal thoracic, it has 2 names. So it comes right off the subclavian artery, which is great for an LAD stenosis because these arteries are pretty much patent for about 20 years. So this patient's 77. So if you think of 20 years that this patient's going to have blood flow to their LAD, you know, they're going to be 97, which is great. So it'll pretty much last him the rest of his life. So that's why we use that IMA for the LAD. No matter what type of stenosis they have, whether it be their right coronary or their circumflex or anything like that, we always do the lima to LAD and the saphenous usually to the rest. So then we have to place the patient on bypass. So bypass is pretty in depth, and it depends on the type of procedure you're doing as to why you would want to use like a single venous cannula versus two. So this just shows a single venous cannula, but because we're doing a mitral valve, we need to come in between the two atria. So the heart has four chambers: your right, your left atria, and then your two ventricles. So if we need to access this valve right here, which is the mitral valve, we need to go in through the left atrium. So we actually need to make sure the venous cannula goes into the IVC as well as the IVC is down here, the SVC and the IVC, which are the venous. And then we put an arterial cannula, and this is how we oxygenate the patient because we stop their heart. So we need to make sure that we're sending blood to the brain, we're sending blood to the legs so that nothing dies while the patient's heart is completely stopped and open. So it looks pretty in depth. These are the cardioplegic cannulas, and that's how we actually arrest the heart. Is we send really high potassium in there, and that raises the resting membrane potential of the heart so that it's harder to generate an action potential, and that's how we actually can stop it. So it's a super high potassium solution. So for our patient, he had pretty severe complications putting in the valve. So the first valve, it was honestly just too big. So a lot of the times we size the valve to this annulus, which is kind of like this big circle right here. And if it sits over the top, it actually can push on the conduction system and it can cause you to have arrhythmias. So if the valve is too big, that's really not good. And we didn't realize that until after we had already placed about 12 sutures into the valve. So we suture this little area right on the outside. So we ended up having to take all those sutures out. So then we went down a size and we started suturing the valve, but these black strings right here were broken on the second valve. So that's the cinching mechanism, and that's actually how we get it to spring open in the heart itself. So we had to take that out again. So the problem with the fact that we had to put 3 valves in this patient is now that they're on bypass a significantly longer time, which is increasing this patient's risk of the disease state he will develop. So it's important to know that it took so many tries to get this patient's valve to actually be in and be effective. So while we're weaning the patient from bypass, he doesn't look very good on the monitor. So we put swan catheters, which goes into your neck down into your heart, to monitor your hemodynamics while you're on surgery. And those are continuous on the monitor ahead of us. And we noticed that, his blood pressure is really low. His cardiac index was kind of marginal at 1.5. And he just, he didn't seem like he was coming off the pump very easily. And his heart seemed to be working really hard to generate even a very low blood pressure. His cross clamp time, which is where we put this giant clamp on the aorta so that blood doesn't go into the heart, and that's how the bypass machine is able to send blood to the other areas of the body. And his was 195 minutes, which the average cross clamp time for a normal cardiac procedure is anywhere from 45 to 55. So obviously you can see his is pretty significant. And his total bypass time was 224 minutes, where the average is, about an hour and a half tops of actual, oxygenation from the bypass circuit. So you guys probably won't know this, but a normal cardiac index is anywhere, like you or I would probably be about 4. So anywhere from 2.5 to 4 is a normal cardiac index. And his was about 1.5, which is pretty low. We like our patients coming off pump to be at least 2. So his was a little too low for our liking. We were trying medications and it didn't seem to be bringing it up at all. So we decided to put in this balloon right here. It's called an intra-aortic balloon pump. So you go in through the femoral artery right here, and you just follow this black line. It goes right all the way up the aorta, just distal to the subclavian vein, which is where the lima comes off of. And what it does is it inflates when your heart is relaxing and diastole, and it actually increases coronary artery perfusion. And then it deflates when your heart ejects blood, and that decreases what we call afterload. So the systemic resistance that your heart has to pump against. So it basically just helps your heart so that it doesn't have to work as hard to perfuse itself and eject blood to the body. That is the whole point of the balloon pump. So we thought, maybe he just needs a little bit more help because we had arrested him for so long that maybe his heart just needs a little more time to come back, which can happen. And so while we're closing, so like these are the types of vitals we see on the monitor. These aren't his vitals. This is just something from Google, but to give you a better picture of what we see in the OR, you see their heart rate, their rhythm will be right here, their oxygen saturation with a waveform, their blood pressure, because we'll put an arterial line in. So we don't just do like the cuffs you get at the doctor's office. We actually put in an invasive catheter in your usually your radial artery, but depends on the patient. Sometimes if that doesn't work, you can go in the femoral artery, so that we can have an accurate measure of your blood pressure. Your pulmonary artery pressures are going to be from that swan catheter that goes through the vein in your neck into your heart, right into the pulmonary artery. And then your end tidal CO2, which is from where you're intubated to make sure that we're oxygenating you appropriately. So we can see our patient's vitals are really not good. His blood pressure is 64/36. So if you know what a normal blood pressure is for a typical, 75 kilogram person, it's going to be like 120s, over 70s to 80s. His mean arterial pressure was 50. His systemic vascular resistance was 560. So normal for that one is like 800 to 1200. His pulmonary artery pressures were pretty high. We usually say like quarters over dimes. So anywhere from like 25 to, 10s to 15s is normal. His CVP, so these are filling pressures, was 18, and that's a little bit elevated. His cardiac index came up after the balloon pump, so at 2, which was a good sign, but everything else kind of looked pretty marginal. So does anyone know the mean arterial pressure is required to maintain organ perfusion to the rest of the body? So it's 65. So obviously with a map of 50, he's not perfusing his organs. So now we need to be concerned about his belly, his kidneys, his brain. So with his blood pressure being so low, we're not sending blood to the organs and tissues that need it most right now. So that's a problem. So my preceptor at the time, he was like, Chelsea, it's really important to always check on your patient's vitals while you're closing. And because I hadn't seen these yet, I'm very into closing the patient's chest. And so that was kind of my face. And I was like, whoa, I'm like, this patient is not doing well. We had started putting him on a lot of pressors, a lot of inotropes. So inotropes help with the squeeze of the heart. So we started giving him a lot of medications. So my instant thought is, well, the patient's bleeding. Like, his blood pressure is super low. His mean arterial pressures are low. We've tried all these medications. They're not working. So I asked the nurse what's in the chest tube, and she said about 100 in the last 20 minutes. So does anyone know what a concerning amount of chest tube output is, or what's defined as surgical bleeding? So 100 cc's in an hour, it means it's warranted to work it up and order lab values, but 200 cc's in an hour is defined as surgical bleeding until proven otherwise. So if this patient had put out 200 cc's, we would need to open their chest at that point. But because it was only 100, we decided we were going to send off labs and see, what's kind of going on with this patient. So we have a pretty big differential at this point. It could be an arrhythmia, but unlikely because we usually are pacing the patients. We put little wires on their heart before we close their chest to make sure that we don't have to induce an arrhythmia. But the patient has a history of AFib, so maybe it's just not registering on the monitor and the pacing wires aren't working as well. That definitely could be a possibility, but very unlikely. For cardiac causes, a paravalvular leak. We changed the valve and we had to change it 3 times. It's very possible that we didn't suture it appropriately and now the blood is going around the valve instead of through the valve like it should be. Myocardial stunning. So just like I said, we arrested the heart for a really long time. So there's a possibility that there's still just too much potassium in the heart and that it's just not generating that squeeze to get the blood to the rest of the body. The conduits could be failing. So the lima, we could have sutured it all the way closed and it's actually not giving blood to that aspect of the heart, and we made our own MI. The ventricle could have ruptured and now he's bleeding into his chest. The cross clamp could have caused a dissection of the aorta and now he's bleeding internally from that. The periosteum on the sternum could be bleeding. All of these things could be happening and we don't know because the chest is actually closed at this point. He could be in shock. There are 4 different types of shock. There's cardiogenic, hypovolemic, distributive, and obstructive. So cardiogenic would be kind of like some of the things I've already mentioned: a heart attack, any of the cords rupturing or the heart rupturing. Hypovolemic is from types of bleeding. So that could be something from the chest wall that, we didn't cauterize or clip appropriately. And now he's bleeding into his chest, causing a tamponade, which could definitely happen. And that would cause an obstructive shock so that the heart actually can't fill appropriately because there's so much blood in the chest. He could be third spacing. A lot of the times our patients get severe capillary leak from how much fluid we're giving them in the OR from the bypass machine, and their like platelets and all their coagulation factors actually start to deplete because they get beat up in the tubing of the bypass. So all of these things are possible and we don't really know. He could be having a retroperitoneal hemorrhage from the balloon pump. When we stick it in the femoral artery and you go all the way up, there's a very real possibility that you could rupture the aorta. We do it under ultrasound from the echo, so it's least likely, but it definitely could be happening, or any of his anesthetic medications that he's receiving. So like I said, his vitals are being monitored throughout the case. So, but in the computer, they only register them every 15 minutes, but in the OR, we're looking at them in real time. So it's kind of hard to give you an exact replica of what we were seeing with every intervention we were making. So we tried giving him blood. We tried giving him platelets. We tried giving him any type of coagulation factor you can think of. I'm not sure how familiar you are with them, but there's different types called like FFP, cryoprecipitate, factor 7, all of these things that are supposed to help your body clot, because we're like, well, he does have a lot of chest tube output. His blood pressures are still really low. We started maxing him out on inotropes, so that's helping that heart squeeze to help try to pump more blood out, like milrinone and dobutamine. We put him on a lot of pressors that squeezes the blood pressure on the outside, so the periphery in your arms, your legs. And he was on, Levophed and vasopressin, and you can tell it wasn't really working. His pressure's still pretty much in the 60s and the 50s, with his MAPS really not at perfusion level. But his cardiac index looked pretty good, which was surprising because you'd think that his cardiac index would be low if he's requiring all these medications just to maintain a MAP of 50 to 60. So our labs finally came back. He doesn't look acidotic. He's actually in the pretty normal range. His clotting factors actually looked pretty good. Like I said, the bypass machine can eat them up. So a platelet count of 106 actually isn't that bad. I've seen platelet counts as low as 32 before. So um, none of those signaled to us that he had some type of coagulopathy that we would need to be concerned with. And so, my preceptor was like, you have to think, you have to stop and think. We've tried every type of blood product we can think of. His labs are normal. He's maxed out on pressors. What do you think is wrong with the patient? And I kind of stopped and I was like, what could be causing this patient to not maintain perfusion pressure but still have a normal cardiac index, which is the most important factor? And I said, I think he's a little bit plegic. And that's how we came to our diagnosis, was vasoplegic syndrome. So it's a very rare type of shock outside of cardiac surgery. So in cardiac surgery, it's actually pretty common, but outside of cardiac surgery, it's very rare. It still can happen, but rare. So it's almost like a septic shock, except you don't have an infection. You have severe systemic vasodilation, and it's refractory to pressors, which normally increase your blood pressure in any other type of shock. So the actual definition for it is severe systemic dilation with a normal cardiac index, and it's refractory to vasopressors like Levophed, epinephrine, vasopressin, those types of medications. Other smaller criteria are your MAPs are usually less than 50. Your systemic vascular resistance is less than 800. There's an absence of an infection, which our patient, being already given antibiotics and only in the hospital for a day with no fever or white count, the chances of him having an infection are less than 1%. So the incidence is only 5 to 8%. And I know that sounds really low, but now that I'm in practice for the last 2 months, I've seen it at least every other week to every 3 weeks. I've seen somebody with vasoplegic syndrome. The etiology, so the cause, that's what that means, is really unknown. There's a lot of theories that say it's related to the bypass machine by your blood going through the tubing and getting all your coagulation factors, beaten up and causing this systemic inflammatory response, causing this severe capillary leak, but they have not proven that yet. So, does anyone remember our patient's risk factors from his history that we talked in the beginning based off of the risk factors here? So, these are all risk factors for vasoplegic syndrome. Does anybody remember anything from our patient's history that correlate with these? So, he was taking lisinopril, which is an ACE inhibitor. He had a severely prolonged aortic cross clamp time at 195 minutes. He's a male. He has increased age because he's 77 and his BMI was 42. So he was obese. So he pretty much had almost all of them. So he was at high risk for this syndrome. So to kind of understand what vasoplegic syndrome is, you kind of have to know the normal physiology of arteries. So here's a typical artery. You have your adventitia or your tunica externa, your tunica media, which is the muscular layer, and then the tunica intima. So we're talking about the media layer, that middle layer. So if you come over to this picture, you can see that calcium is a voltage-gated ion channel. So things that can make calcium influx are going to be norepinephrine, Levophed, angiotensin 2, vasopressin. So it can either be a neural stimulation or it can be hormonal, like these vasopressins, ADH, those types of things. And what happens is once that causes that action potential, the calcium comes in and it gets phosphorylated so that you can have those myosin and actin binding, and that causes a contraction. So that causes your media to squeeze your blood pressure, and it increases your systemic vascular resistance and your blood pressure. So the problem in vasoplegic syndrome is from the bypass machine, you get all these interleukin factors, tumor necrosis factors, cytokines, inflammatory mediators, right? And they increase what's called nitric oxide synthase. And what that does is that causes an increase in nitric oxide. Nitric oxide is a systemic vasodilator. So you can imagine if you have a lot of nitric oxide in your body causing vasodilation, now you're trying to counteract that by causing a squeeze, right? And you think you'd be able to do that with your normal catecholamines like norepinephrine or epinephrine. But what happens is
Ready, Judy?
What? Okay, there's so much nitric oxide that your body is making all of these catecholamines and they actually get depleted because your body's just shooting so much out. You know, you're shooting so much adrenaline out. You're in that fight or flight mode. And then it actually down regulates the receptors that you have on that membrane. So you can't influx calcium that way. So then we try to give you these medications, but now all these receptors are down regulated and it's not working. So you can imagine how nitric oxide is getting then diffused into the smooth muscle cell and also blocking calcium receptors from the cyclic AMP or CMP. And now you're kind of just fighting this losing battle where you can't get calcium in to get that squeeze. And all that keeps coming in is nitric oxide, causing more of a dilation, causing that low blood pressure and inability to perfuse your organs. So most of our patients are intubated, sedated in surgery. They can't tell us what's wrong. So clinical manifestations or symptoms is really just your normal cardiac index and severe hypotension that is non-responsive to medications. There's a super high mortality if it's unrecognized, like 50% in the first hour. These patients, if you can't perfuse their organs, they're at really high risk of strokes, seizures, neurologic complications, renal complications. Our patient's creatinine was already elevated, so he's already at risk for some type of kidney injury. So we're not perfusing those organs that are important. So he's at risk for a lot of complications. So it's a clinical diagnosis. You kind of just have to put their vital signs together and know, like, you've tried all these other medications and they're not working. And you kind of just hope for the best and hope that you're right. Because if you're wrong, the patient could die. So to treat them, your first line medication is going to be that norepinephrine or that Levophed. That's the other name for it. And that's because it's a direct alpha agonist. So that's going to work directly on that tunica media to try to influx calcium. You know that those receptors are down regulated, so you just hit them with all you got. You try to just keep giving them as much as they can take. Vasopressin is your second line, so that's going to be that hormonal stimulation to the tunica media, and that works directly on the V1 receptors. You can try steroids. You're just trying to decrease that Sears response, that inflammatory response from the bypass, to try to decrease those cytokines and decrease that nitric oxide production. And then if you're in really desperate case, you can try methylene blue, which is a guanylate cyclase inhibitor, and that's going to try to block nitric oxide production, which in our patient is what we did. So we are like, nothing's working. He's maxed out on every medication we can think of. Let's try methylene blue. So what it does is it blocks nitric oxide synthase from making nitric oxide. So now the nitric oxide can't diffuse into the muscle cell. So it's not going to cause vasodilation. So that's the whole mechanism behind methylene blue. And in our patient, it started to work and we were able to stabilize him enough to take him to the ICU. So over the course of his 2 days, we were able to wean his pressors and his inotropes. We were able to extubate him. We were able to take out his balloon pump, and he ended up going home on post-op day 7 with not a single complication. So it was really amazing to see how fast he bounced back once we gave him this methylene blue. His MAPS increased right to like 60. Once we gave it to him, his pressure stayed pretty much in the 70s until we took him to the ICU. And then, as you can see on post-op day 1 and 2, he was pretty much 80s over 60s. Post-op day 3, hundreds over 60s. So obviously we were perfusing him appropriately, and that's how we were able to get, that balloon pump out. And he ended up going home on day 7 with no complications, which is what made me fall in love with cardiac surgery, because we were able to recognize it within that hour and pretty much saved his life. So the take-home points for this syndrome is you need to keep your differential wide. It's really easy to get tunnel vision when you're looking at patients. It was very easy to say, oh, he had a lot of chest tube output and he was hypotensive. It's super easy to say like, oh, he's bleeding, let's just open up the chest. But obviously that's not what this patient needed. And it was good that we tried other things prior to going back into his chest, because if we did that, we would have missed his diagnosis and he probably would have died. There's limited tools to identify and treat vasoplegic shock. It's a highly researched diagnosis and very poorly understood. Like I said, they're not even sure what truly causes it, but they know that patients who take certain medications and are on bypass for a certain amount of time are at higher risk, and more so than patients who don't undergo cardiac surgery. There's a lot of neurologic and renal complications, so you need to make sure that you recognize it quickly. Those were all my references. I tried to keep it at 30. Sorry, guys. I know it was a lot of information, so feel free to ask me. I tried to use as layman terms as I could, but feel free to ask any questions about it or about cardiac surgery or PA school in general.
So if you guys want to ask questions in the chat, or I can read them out loud, or if you guys just want to unmute yourself. So someone just said that they loved your TikTok.
Oh, thank you.
And what made you want to be in PA?
So when I was in undergrad, I thought I wanted to go to medical school. And I ended up getting pregnant. So I just started working as a tech, and that's how I became exposed to the PA field, was working as a tech. And I realized that I didn't actually want to be a doctor. I liked the work-life balance of a PA. I liked that you could spend more time with patients. I liked that I could still diagnose patients and treat them. But I was able to change specialties. So if I want to work in the operating room for 20 years and then I'm like, I'm too old to do this, I can go to family med, or I can go to primary care, or I can do anything else. I can go to any specialty. Whereas like doctors, they can't change specialties. Once they're board certified in one area, that's where they stay, or they have to get a double certification. I don't have to. And I don't need to be the top dog. I don't need to be the here end all be all. I'm fine with admitting that I don't know something. And like, I think about doctors and I'm like, who do doctors go to when they're unsure about a patient's diagnosis? And I see it all the time. And, they're like, oh, I'm not really sure what's going on with this patient. And I'm like, well, for me, at least, if I don't know what's going on, I can ask one of the physicians, hey, can you like bounce ideas off of me? So I liked that about the PA field much better than becoming a doctor. So it just fit better with my personality.
The next question is, as a PA, how much do you get involved in surgery?
I'm in surgery every day, all day. So I do my own harvest in the leg. So I make the incision, I harvest the vein, I close the leg, I do everything by myself while the surgeon is up at the chest, and then I go up to the chest and assist him with the rest of the case. In cardiac, you get a lot more involvement in surgery than say general surgery, which is a lot of laparoscopic cases. I'm I'm suturing in things on the aorta. I'm suturing things on the atrium. So that's why it causes a lot of training to be in cardiac surgery, which is why I chose a residency, is because we do so much in surgery as a PA. So I do quite a bit. I'm probably in the operating room at least 30 hours of my 70 hours a week.
That's a lot. Um, did you learn more on the job training or more in like PA school?
On the job training. As a PA student, you don't really get to do much. They kind of just make you watch. And that's just because of the liability for patients. So I did a lot of watching in my rotation, but since I've been practicing, every case I get to do more, which is great. So
Where people are definitely complimenting you on your TikTok.
oh, thank you.
So, one person wanted to know, how did you manage your time and like learn so much in like PA school and everything? Like, how did you balance that like PA school life?
Oh, it's rough. So when they say going to PA school is like drinking out of a fire hydrant, it really is. So we're trained in the medical model. So what medical students get to learn in 4 years, you have to learn in 1 year. So it's a lot of information at one time. And what I did was, if I was in class from 7:30 in the morning till 9 at night, I would come home and I would usually meal prep so that I didn't have to cook anything. Like I would meal prep on like a Sunday, and then I would heat up my food, and then I would study till like midnight, maybe 1, and then go to bed. Um, so it's making sure that you're okay giving up pretty much everything else for about a year. I maybe saw my son every 6 weeks for like a weekend, which was really hard. But now looking back, like, yes, the days were long and it was really hard being away from family and friends and, getting those texts that were like, oh, can you come to this baby shower, this wedding, or this dinner? And I'm like, no, I have to study. I have 3 exams this week. It was sad looking at it from that perspective in that moment, but now I look back and I'm like, wow, that went by so fast. And now I'm a full PA and I get to do those things again. So you just have to know that it's not forever and it's going to be a really tough year. Clinical's a little bit easier because you have a little bit more free time. You don't have exams every week. But you have to be dedicated to it, and you have to know it's going to be very, very time consuming.
And somebody wanted to know, what is the difference between being a PA resident and a PA with a master's degree?
I do have a master's degree, so I'm a PA. So I chose a residency, so I just get paid less. That's all it is. I get paid less for a year. So it's just like a medical resident who has already passed their boards and they're an MD, but they have additional training for a certain field. So like the whole reason I did a residency was to learn more in cardiac surgery, so that I could operate better, because we only get 5 weeks of surgical training. I did more electives in surgery, so I had more training than, say, my other 28 classmates. But I'm a PAC, so I took my boards just like everyone else, and I have a master's degree.
Um, so what is your advice for a student applying for PA school?
So my advice is do it early. So, any of your prerequisites, any of your patient care hours, volunteering hours, make sure you know what schools you want to apply to and at least start a year ahead so that you meet all of those requirements. Because I've mentored a lot of students that say like, oh, I want to be a PA, and they start their CASPA application and they're like, oh, I didn't know I needed this amount of hours for this school because I don't want to have to move out of my home state. So do your research. Make sure you know what schools you're going to apply to and what those prerequisites are prior to even opening your CASPA application. Because if you open your CASPA application and then you don't actually submit that year, you're still technically a reapplicant. So just understanding that part of the application process. Make sure that you have all your ducks in a row before you apply, and make sure you know what the requirements are for the schools that you're applying to.
So the next question is, well, the next two questions are like, what's your favorite part of the job? Are you career satisfied? And what do you like love about your profession right now?
So I'm 100% satisfied in my career. And my favorite part, especially being in cardiac surgery, is I get to I get to make patients better. I get to see them sit here and tell me they can barely breathe from getting from the bed to the chair, and then we get them out of surgery and they're like, I feel like a new person. I can breathe, and they're just so grateful, and it's just a rewarding experience to know that I helped this patient get better. Whereas a lot of things in medicine are hard to accept, that you're not going to fix somebody. You can manage their pain or their symptoms, but a lot of the times you can't just fix a lot of things. A lot of things are going to be lifelong for them. You can't just take it away. Whereas like cardiac surgery, we just fix it. So it's very rewarding in that aspect.
So the next question is, I know surgery is very sterile, but there are like a lot of changes and precautions taken during COVID-19, and like what were those and how did that change working?
So elective surgeries were canceled because of COVID, because we're intubating patients, and that's kind of aerosolizing respiratory particles. But specifically for cardiac surgery, you can't stop cardiac surgery, because if somebody has a huge heart attack and they need an emergency bypass, then we do that. So our practice was less affected than, say, general surgery for like gallbladders, those types of things, because a lot of our patients will die without surgery. Aortic stenosis, even if like if you're passing out, that can signify that within a couple months you might not live. So a lot of our patients were able to still have surgery, but we minimized the staff in the room. Like no students were allowed in the rooms. Anything like that. Like a lot of times people are like, oh, I've never seen heart surgery, and we kind of just let them stand up with anesthesia to watch, but they didn't allow that. So those were the main precautions that we had to take, was just minimizing to essential staff in the room. So the surgeon, the PA, the anesthesiologist, the perfusionist for the bypass, and the scrub nurse. That was pretty much the extent of who was allowed in the room.
Yeah, I know like COVID affected like a lot of people's work, especially my parents who are like in surgery. It like was crazy.
Yes.
But the next question is, what PA prerequisites helped you most in PA school?
Anatomy and physiology, definitely. Microbiology, um, and biochemistry. Those were probably the top ones that I would say helped me the most in PA school. When it came to like acid-base chemistries and those types of things, being a biochem major, I definitely had a better handle than some of my classmates, but also some of my classmates had better handles on, other aspects of PA school. So, but those are the three that I would say helped me the most in PA school.
What PA, sorry, where do like you get recommend doing like medical patient hours, and like how many clinical hours did you have before PA school? And like what?
So there are a lot of different places that you can get patient care hours. I chose to do mine in an outpatient and inpatient setting because I wanted just more experience. So I did outpatient orthopedics, and then I did inpatient psychiatry. Um, but you really can do pretty much anything. I think really great ones, but they need certifications, are CNAs, LNAs, EMTs. They all have different benefits to them. And that's the best part of PA school, is when you all come together, you realize that one person's strength is another person's weakness, and you guys can help each other with that. We had EKG technicians, and I had never worked with EKGs. So I was able to be like, oh, Tommy, can you help me learn EKGs? But like for ortho, I was able to help teach my classmates like how to do physical exams on patients with, fractures, or how to cast and those types of things, or how to talk to a psychotic patient and be able to de-escalate them. Like everybody has different benefits to their background. So I think all patient care hours are very valuable, whether you are a home health aide, a CNA, an EMT, a nurse, a respiratory therapist. Everybody will bring something to the table, and you're going to notice that in PA school. Whereas, like, in medical school, you're not required to have patient care hours. So, a lot of the times you don't have that benefit, whereas PA school you do, and you can learn from other people's experiences. So, I really don't think there's you should do this for patient care hours. I recommend anything that you're interested in that exposes you to PAs. I think that's important.
Since you specialized in cardiothoracic surgery, would you still have the lateral mobility of like, could you change specialty and like work as like a pediatric PA if you like wanted to?
Yep, I could do that next week if I wanted to. Just because I'm doing a residency does not mean that I can't change specialties. It just means that if I stay in cardiac surgery, they have to pay me more. That's pretty much the extent to it.
Do you have a lot of volunteer or community service hours before you applied to PA school?
Yep. So I did community service through my sorority throughout undergrad. And then I also would do community service at like a soup kitchen every week while I was working as a tech, just to keep my hours up. I think it's very important. It shows selflessness and dedication to others or underserved communities, which is a huge aspect of the PA profession. So I would suggest making sure that you do volunteer hours. And my recommendation is don't do like, oh, I went to this cemetery cleanup once and then I did this one thing one weekend for 3 hours. Like have something that's consistent, because it shows dedication, and that's what you want your PA schools to see. So have like, whether you help serve food at the food kitchen for 1 hour every Tuesday, that means more than being like, oh, I had 15 3-hour community services that were scattered. But if it's like, oh, I dedicated my time 1 hour every week to this soup kitchen, and I got to develop relationships with these people who came in and developed professional relationships there, that's something that brings something to the table for your interviews in PA school, and those have more merit. That's my recommendation for that.
That's all the questions that were in the chat. So if you have any other last minute, oh, there's one. Okay. Does it really matter what bachelor's degree we get to apply for PA?
Nope, you can have any bachelor's degree. You just have to make sure you meet the prerequisite requirements for specific classes. So like as a biochem major, I didn't have to take A&P or micro. So I took those at a community college while I was working as a tech to make the prerequisites to apply to PA school. So just making sure that you meet all those classes. Sometimes different programs will ask for different things. Pretty much every program will have you take Bio 1 and 2, Chem 1 and 2, Orgo 1 and 2, Biochem, A&P, and Micro. But a lot of programs will ask for genetics, physics, statistics, those types of things.
Someone just wanted to know, did you take a gap year between your undergrad and PA school, or was that like when you were working?
Yep, nope, I took a gap year because I had my son my senior year of undergrad. So I worked, became a tech, and that's how I even found out about the PA field. I didn't know about it in undergrad.
And approximately, I guess, how many volunteer hours did you have?
I want to say it was close to 300 total. And then my patient care hours was like 6,000.
Okay, that's a lot. That's a lot. Did a PA or doctor write you a recommendation for your?
Both. So I had 2 PAs, 1 MD, and a professor write me letters of recommendation. I recommend having both write you letters, because as PAs, we do work with doctors. So if a doctor and a PA will vouch for you, that holds more merit than, you know, 3 professors that are like, oh, they're a straight A student. You know, you want someone in our field to recommend you. So you want a PA, you want a doctor because you're going to have to work with a doctor forever. That's part of our field. But I recommend both for sure.
Have you worked in different hospitals during your gap year?
So during my gap year, I worked for the same hospital, but like system, but I worked inpatient in psych, and then I wanted more exposure to PAs because I really didn't get that in psych. I worked with like one PA, which I loved, but I really wanted to see other aspects of the profession. So that's when I went to outpatient orthopedics, but it was still through the same hospital system. I just went to outpatient.
That's all the questions in the chat. So if any last minute questions, you can go ahead and ask or unmute yourselves. But other than that, I'm not sure if I mentioned this, but what did you work as before, like during your gap year? That's the question.
Orthopedic technician and psychiatric technician.
Okay. But other than that, yeah, thank you so much for this incredible and insightful session. Chelsea, I really enjoyed how thorough your explanations were, especially on the case study. I hope to have a session with you again in the future. I actually attended 2 of your sessions previously from other organizations. That's how I found out. But if you'd like to post your social media handles or links to your business or endeavors at all, please feel free to do that in the chat. To our Wayne State University students, please make sure you complete the Google survey posted in our Zoom chat that Parshva posted, so you might need to scroll a little bit up. Summarizing the session to obtain your shadowing hours. Thank you so much for coming and have a great night.
Thank you, guys. So my Instagram, I just made a specific pre-PA Instagram because it was kind of linked to my personal one. And now that like more pre-PAs have been reaching out to me, I just made a specific one that talks about when I do Zooms. My fiance does free organic tutoring, those types of things. So that's going to be that Instagram handle. And then my TikTok is Chelsea and 03. So if you guys have any other questions, you can feel free to message me on those. I respond to all my messages that I get, but sometimes it takes me a while because I do get quite a few direct messages. So if it takes me a couple of days, sorry, but I do respond to all of them. So feel free to reach out if you have any other questions. Thanks for having me. I hope you guys all have a good night.
Yeah, thank you.